I'm honored to be here as one of the honorary members of the European Society. I don't have to pay membership dues anymore. And so it's really so I get to come here for free. I coined the term functional hemodynamic monitoring many years ago as a way of separating it out from hemodynamic monitoring. But before I do that, I have to tell you about my conflicts of interest. These are my important conflicts of interest. This is my wife and 3 children. These are my unimportant conflicts of interest. I have a patent that the University of Pittsburgh owns on functional hemodynamic monitoring. I have 2 other complexity U.S. patents that don't relate to this. I've been a medical advisor to every known hemodynamic monitoring company and actively these. And I'm the principal investigator on 3 NIH grants, which is, of course, the most important conflict of interest. Okay, what is functional hemodynamic monitoring? It's the use of a defined, reproducible, and quantifiable physiologic stress, and I don't even care what it is, but a defined, reproducible one that allows you to elicit a body's cardiovascular reserve. And it uses it by measuring dynamic responses. So you first have to put in a dynamic stressor, and the second thing is you have to be able to measure its response. For cardiac output, for example, we need to use the arterial pulse contour devices or the impedance cardiography or esophageal Doppler or something like that, because you want to look at the dynamic changes in flow. For arterial pulse pressure, you need to have a continuous measurement of the arterial pressure waveform, which can be measured both invasively and non-invasively. But no matter what it is, you need to look at a dynamic response. The corollary to this is an electrocardiogram versus an exercise EKG. If I were to do an electrocardiogram on anyone in this room and it was normal, does that mean you don't have coronary artery disease? Of course not. You could have terrible coronary artery disease and have a totally normal ECG. But if I do the ECG and I put you on a treadmill and I increase your cardiac output to 80% of your maximal amount, and I get to a certain level of oxygen consumption, and there's no ST segment depression, J-point elevation, or T-wave inversion, I can be 99% comfortable that you do not have clinically significant cardiovascular disease. Have I changed the ECG? No, I haven't changed one bit the monitor, but I put into it a functional measure that allows me to develop emerging parameters that are highly intuitive and sensitive and highly specific to ask the question, do I have cardiovascular reserve? So using that, we and others have documented that we can determine volume responsiveness, vasomotor tone, contractility, and cardiovascular reserve. And in all cases, the reference at the bottom is the first reference, not the last, to show this. Okay, there are 3 primary clinical problems that I think we address. One is how to identify patients who are becoming unstable before they progress too far, because if you treat them early, they do better. The second is how to determine the most appropriate therapy to reverse the primary cause of circulatory shock. And the fourth is how can I then manage these patients in a consistent fashion across patients, doctors, and training centers. All of these can be handled by functional hemodynamic monitoring, but in today, and this specific lecture, all I'm going to focus on is number 2, how to determine the most appropriate therapy to reverse shock. But all of these have things that functional hemodynamic monitoring have developed. So the functional questions you want to ask with regards to reversing shock are, will the cardiac output increase in my patient who's in shock with fluid resuscitation? And if so, by how much? Because if cardiac output won't increase with fluid resuscitation, then I shouldn't give fluid to that patient, right? It's a bad thing. Second question is arterial tone increased, decreased, or normal? And the reason I want to know that is if I have hypotension, what will increase mean arterial pressure? Because I need a high enough mean arterial pressure to maintain organ perfusion and blood flow to the vital organs. And finally, is the heart able to maintain that flow under a certain perfusion pressure without going into failure? And I submit to you that these are the 3 primary physiologic questions you ask of the cardiovascular system in the management of your patient in shock. You know, you might ask stuff about pulmonary hypertension, they have a pulmonary embolus, yeah. But these are the primary questions that you ask. Okay, so the first question, let's say, is the patient's cardiac output responsive to intravascular volume loading? Well, if you're going to be academic, you'd assume that the venous return, which Dr. Jan Bakker will show you in the next lecture, is the primary determinant of cardiac output, and that right ventricular preload and venous return are linked, and therefore you're going to evoke Starling's law of the heart. That's a nice way to go. And you're going to assume that if you have a low left ventricular end diastolic volume, that you're preload responsive. I'm sure you've heard echocardiographers say to you, the walls of the heart were kissing, the heart's totally empty, fill them up. And that's what you'd say. And so what you would look at is you would look at estimates of left ventricular end diastolic volume as surrogates, such as CVP, pulmonary occlusion pressure, left ventricular end diastolic area by echo, right ventricular volumes by ejection fraction, or interthoracic blood volume. These are all surrogates for preload. Okay, well, why don't you just give every patient who's in shock a bolus of fluid? Give a liter of balanced salt solution to this patient, let's see what happens. Well, the signs of cardiovascular insufficiency are pretty impressive, but they're nonspecific. Hypotension must decrease the blood flow of the heart and the brain, and that's not good for survival. And most forms of circulatory shock have a pathological component of decreased effective circulating blood volume. So what we often do is a fluid challenge, which is if you think a patient is hypovolemic and is going to be volume responsive, you give a small volume of fluid really fast, and you look if the cardiac output increases. Interestingly, a recent paper that was published by the Fineschi group in intensive care medicine showed that although we say this, less than 20% of all patients who are in shock who are given a fluid challenge really have it assessed in terms of does it improve cardiac output, blood pressure, or urine output, or perfusion. They just give it and see if the patient looks better. Well, why don't we simply just give every patient fluid? In this meta-analysis by Frederick Makar and Jean-Louis Thibault years ago, they looked at all the studies in which people measured preload parameters, and they saw if they were responders, which was this group, or the non-responders. And these are a bunch of studies, and I'm actually an author on 3 of the papers that they reviewed. And what you can see is that if you look at the average, approximately 50% of all patients who present in shock, whether it's in the operating room, the emergency department, or on the floor in sepsis coming to you, only half are volume responsive. Now, if you're playing baseball in the United States and you have a batting average of 500, that's pretty good. But if you're an ICU doctor, that sucks. Okay? You're, first of all, delaying the right treatment in half the patients. And second of all, if the patient has core pulmonality or left-sided pulmonary edema, you'll make them worse. So the blind infusion of fluid for the treatment of shock in every patient without assessing them first is not indicated. That's an important point that really needs to be underlined. There is no question that saline can be dangerous. All my pictures are, by the way, true. They're not photoshopped. So, is the cardiac output adequate? Is the blood flow adequate to meet the metabolic demands? If I increase intravascular volume by giving fluids, will cardiac output go up? If I give PEEP or positive pressure breathing to decrease venous return, will cardiac output go down? From a physiologic perspective, what we're asking is our patient preload responsive? Well, there is no relationship at all between CVP and total circulating blood volume. As Jan Bakker will tell you in a minute, there shouldn't be, because total blood volume is a function of your stressed and unstressed volume, which can change in moments with vasomotor tone and blood flow distribution, which is the reason why you don't faint when you stand up, for example, because you don't change your blood volume, but I can increase vasomotor tone and increase venous return to match it. Otherwise, everyone in this room would faint when they stood up. And you know that's true because you have heart failure patients and patients with dysautonomia, and what do you tell them? Well, don't stand up from lying down, just sit up at the edge of the bed, angle your feet, feel good, then slowly stand up because you can't arrange your blood flow distribution that well when you're sick, whereas in you and I, we can. And that's because your total blood volume doesn't change, but the amount of unstressed volume changes. Dr. Jan Bakker will describe that in great detail in the next talk. Well, Neither CVP nor pulmonary pressures reflect preload. In this study by Kumar, and there are numerous ones out there, this one's just the prettiest. They measured everything they could think of in patients in shock that were being resuscitated, and there was no relationship between right ventricular end diastolic volume and CVP, or its change and the change in CVP, or the same for the left ventricular end diastolic volume and wedge pressure. And if you ignore that, there was no relationship between stroke volume and its change in either CVP or pulmonary occlusion pressure. And this is not the only study that's shown it. Numerous ones have. For the sake of time, I'm not going to bore you by showing you them, but there are at least 50 papers that have all shown the same thing. So if you learn nothing else from this talk, please learn this. Preload is not preload responsiveness. I can have a big ventricle and be volume responsive, or I can have a small ventricle and not be volume responsive. The most common form of heart failure today is diastolic dysfunction. It's heart failure with preserved ejection fraction. You can't give those people volume, yet they have a small heart. They won't do well if you do that. And patients with big hearts often are volume responsive. Okay? I'm not giving you mixed signals. This is real physiology, and this was known since 1900. What I'm showing you here is an example from 1959, only because it's one of the prettier examples. And what you're seeing is that the determinants of cardiac output are preload, afterload, heart rate, and contractility. In this model, in which the heart rate is constant, what I'm showing you is that here we have the left ventricular end diastolic volume in an isolated perfused human heart. And at the moment you can see that the stroke volume under normal conditions is from the bigger volume to the smaller volume. So what do they do first? They markedly increase the venous return to the heart, and they keep the flow up. And you can see that there's an immediate increase in stroke volume. Starling's law of the heart. No two ways about it. Absolutely, there it is. But look, over time, over about a minute or two, with the increase in flow, intrinsic contractility increases. This is known as the Anrep effect. And stroke volume remains elevated despite the fact that the end diastolic volume is actually lower than it was before. This is normal physiology. In you and I and our patients, we increase our cardiac output from a left ventricular perspective by changing contractility. As a matter of fact, the American College of Cardiology defines heart failure as those patients who have to use the Starling mechanism to increase stroke volume. Because in you and I, we don't. So there's no reason that there should be a relationship between preload and output, because the heart changes contractility on its own. So what can we do? Let's use the Starling law of the heart to our effect by looking at dynamic changes in preload that occur during breathing. Since the heart is in the chest, a pressure chamber inside a pressure chamber increases and decreases in intrathoracic pressure must affect the pressure gradient for venous return independent of the heart itself. It's a beautiful situation of air on top of water. Now, this is a study which I published in 1984, and I want a show of hands here. Who here in the audience was not born yet in 1984? Raise your hands if you were okay. So I can comfortably tell you, before you were born, we knew this. Okay. So let me show you what we knew. This, and by the way, this paper was not the first to show it. It just was one of the prettier examples. What we do is I took this animal model, I put a flow probe on the pulmonary artery and closed up the chest, let the animal recover, and you can see with spontaneous inspiration, pleural pressure, which is shown in this kind, goes down, and with positive pressure breathing, pleural pressure goes up, as you'd expect. Note that with the spontaneous breath, since the pleural pressure went down slightly, it makes CVP decrease. Right ventricular filling goes up, and right ventricular stroke volume goes up. With positive pressure breathing, the increase in airway intrathoracic pressure from the increase in lung volume causes CVP to go up, causes right ventricular filling to go down, and this causes the stroke volume of the right ventricle to decrease if you're volume responsive. So we can use this phenomena, since every patient on positive pressure breathing will have a decrease in venous return proportional to their pressure gradient for venous return. I can use this to dynamically look at them. So with Andre Deneau, years ago, we went into the operating room, and using a transesophageal echo with an automated border detection algorithm, which in those days, which was 15 years ago, was novel, now it's common. You can see here, here's the left ventricular in diastolic area, and then the heart contracts down. Here's a positive breath, and you can see how in a normal human being, dynamically, at the end of inspiration, from the decrease in venous return, the left ventricular volumes fall, and you see that the pulse pressure also decreases. So I want to go back and give a little bit of physiology. I apologize, but it's useful to explain it. If we were to look at left ventricular function as a pressure-volume relationship, in which there is the pressure is on the y-axis and volume is here. When there's minimal pressure and volume, the heart's finished ejecting, the mitral valve opens, and there's filling of the heart until the heart starts to contract, the mitral valve composes, and boom, there's isometric contraction until the pressure in the left ventricle equals the pressure in the aorta. The aortic valve passively opens. The heart continues to contract as stroke volume occurs until you get to end systole, and then there's passive relaxation. So stroke volume is the difference between end diastole and systole. So I can look at the left ventricular pressure-volume relationship corkscrewing through time in this animal model from our laboratory, and you can clearly see how dynamic the changes in preload occur associated with positive pressure breathing. Okay? It's like a whale in a sound. The surface of the water never changes, but your relative relationship to it continues to fluctuate. Steady-state cardiac output does not change. So with Young-Gu Kim, we went in and actually measured in an animal model left ventricular pressures and left ventricular volume, and we did it, and we separated out the ventilatory cycle in terms of the pressure volume loops by color, blue for end expiration, green, yellow, and so we have the left ventricular pressure volume loops at different points in the ventilatory cycle for the same animal, one heartbeat after the next. And you can see at end expiration, I have a larger end diastolic volume than end inspiration. So there is my decrease in my preload. And by the Starling mechanism, I see that this stroke volume varies. So that's my stroke volume variation. Okay? So let's assume I have a big heart, and it's good, and a not so good heart. And the two are together. And I have a patient who's breathing at low volumes and they're volume responsive. So I'm going to see their end diastolic volumes oscillating between these points. Well, I'll see a stroke volume variation for both of them. If I start to fill the heart more, the not so good heart will no longer show stroke volume variation. The good heart still will. And if I eventually overdistend it, neither heart will be volume responsive. So it doesn't matter the shape of your Starling curve or where you are. If you have a stroke volume variation with variations in preload, you're volume responsive. And if you don't, you're not. It's that simple during positive pressure breathing. So I can capture that idea and bring it back to Earth. So with Jose Marquez, and we went into the operating room and we would put a flow probe on a human being's aorta, and we measured arterial pressure and aortic flow in a human being as we did an IVC occlusion. And this is the first time this had ever been done in humans, and it took us 3 years to recruit 5 patients. You can't imagine the IRB consent form. Okay. These were all being done right before cardiac surgery, and everyone was going on bypass, but still, and no patient had a problem. But now we had, for the first time ever in human beings, the gold standard for aortic flow and arterial pressure. And what we found was that over the normal physiologic range, stroke volume and pulse pressure change identically. So I can measure pulse pressure in anyone. And the dynamic changes in pulse pressure and stroke volume follow each other very nicely, as Jaime Mesquita showed from our studies in Pittsburgh when he was visiting with us for a year. They're very tightly knit. So you should think of it as a dynamic change that's occurring that in the steady state you would never see, but if you can look instantaneously, it's there. So years ago, when I was on my sabbatical in Paris, Jean-Louis Thibault said to me, "Michael, we're seeing patients who have significant pulse pressure variations, and when they do, and we give them more PEEP, their cardiac output falls. But if they don't have pulse pressure variations, even if the systolic pressure rises, then they don't have a fall in cardiac output when we give them PEEP." And I told him that's just very straightforward, changes in venous return Sharpie Schaefer showed that in 1955. It was called the square wave Valsalva maneuver, and we documented the physiologic mechanism in our animal studies over the next 15 years. And he said, yes, I know, I read them, but nobody else did. Why don't we do a clinical trial to show that what you showed in dogs is true in humans? So I said, okay, but it'll be a boring study because we already know the result, and this is that result. If you were to look at a human being's relationship between the changes in ventilation, here shown as the positive pressure, there's an inspiratory pause and it goes down, you can see that the systolic pressure rises and falls, and the diastolic pressure. If you were just looking at the systolic pressure variation, that's pulsus paradoxus, but it doesn't take into account the true stroke volume, which is the distance between diastole to systole. And that's the true stroke volume variation. That's the pulse pressure variation. So if you look at the pulse pressure divided, the maximal pulse pressure divided by the minimal, that's called pulse pressure variation. And what we showed was that when we gave PEEP to patients, if they had no pulse pressure variation, they had no fall in cardiac output if we gave them 10 of PEEP. This is ARDS patients. But if they had significant hypovolemia and you gave them PEEP, their cardiac output fell. Well, that was good and it was kind of nice, but I said, but everyone really cares about septic shock. And in septic shock, you have vasodilation. So let's see if the same thing is true, but with fluid resuscitation in patients with sepsis. So we repeated the study in a second study in which we looked at the relationship between changes in cardiac index in response to a 500 ml bolus of albumin or some sort of starch versus positive pressure breathing, and it was close to perfect. The greater your pulse pressure variation, the greater the response to fluid. And since it's a test, you can calculate the receiver-operator characteristic. A random test would be somewhere that goes along this line, and the right atrial pressure and pulmonary occlusion pressure in the surviving sepsis guidelines recommendations don't work, and they have subsequently been removed from the surviving sepsis recommendations. You no longer target a CVP or wedge pressure. But in fact, pulse pressure is excellent. Systolic pressure variation, by the way, is not bad. It's not bad at all, but it's not as good as pulse pressure variation, okay? Well, Francois Jardin looked at humans and showed, in fact, that what we hypothesized was happening from dogs was also true in humans, because here you can see that he has 0 PEEP. He goes up to 5 of PEEP. You can see that the inferior vena cava collapses down. The pulse pressure variation goes up, and the cardiac index falls. He keeps him on PEEP and gives him volume. Cardiac output goes up. The IVC stays open, and the pulse pressure variation goes down. So it's not rocket science. It's very straightforward. But you don't need to look at pulse pressure variation or stroke volume. When we did our study, we also measured esophageal Doppler flow and pulse oximetry pleth variability, here shown with a pulse oximeter, and that's totally non-invasive. So anything that can measure dynamic change will work. So the principle, and this is a slide I borrowed from Jean-Louis Thibault, a good friend, is that with mechanical inflation, there's a decrease in the venous return, remember, causing the decrease in right ventricular stroke volume that occurs if your right ventricle has preload reserve. So if you're in cor pulmonale, it won't happen. And of course, this goes on in inspiration. And then after about, 2 to 3 beats, there is a decrease in left ventricular filling, which will then cause a decrease in left ventricular output if the left ventricle has preload reserve, and of course this occurs at expiration. So one can conclude that mechanical inspillation will decrease left ventricular preload if both ventricles are volume responsive. So if I've got cor pulmonale, I won't be volume responsive. I don't care what you're looking at. So the rule is, if you have pulse pressure or stroke volume variation that's greater than about 10 to 15%, you're volume responsive, and if you don't, you're not. So in a clinical scenario here, we have a patient, 25-year-old diabetic female, pneumococcal pneumonia, required intubation. She became progressively hypotensive following intubation. She got 2 liters of crystalloid. She had a PA catheter inserted. CVP was 10. SCVO2 was 58. Lactate was 4.5. She was a sick girl. Cardiac index is 2.5. And regarding her cardiovascular management alone, assuming that her peak Airway pressure is less than 30, so you're doing practice ventilation. What should you do? Should you give more fluids, start norepinephrine, assess pulse pressure variation, or order a spiral CT scan to rule out pulmonary embolus? Well, I hope you'll all agree that what you would simply do is look at an arterial pulse pressure variation, and you'd know in 1 second whether or not this person was volume responsive. So the monitoring truth is, I don't care what you monitor. No monitoring device or calculated parameter will ever improve outcome unless coupled to a treatment which itself will improve outcome. This is a physiologic truth. I can measure ECG all I want, but if I can't treat a myocardial infarction, all I can tell you is when the heart stops. I can't tell you that the patients are going to get better. So I have to be able to use this monitoring approach to improve outcome. I'm pleased to say that in the recent meta-analysis of all the functional hemodynamic monitoring guided resuscitation studies that were done, and this is a paper in Critical Care published by Benes, he was able to show that if you look at all the studies that have tried to use this, that there was a statistically significant improvement if you use functional parameters to give resuscitation. Not shown on this slide, patients who are given fluids only when they're volume responsive actually end up getting less fluid than those that are just given fluid until they no longer respond. Because if you know they're not volume responsive, you don't give them fluid. Okay? But you've got to be careful when you do this or you get into trouble. You have to pay attention. There are technical limitations to the use of the pulse pressure and stroke volume variation, and they're shown here. You need to have a fixed heart rate. So if atrial fibrillation, it doesn't work. Atrial fibrillation is bad, but it happens in 20% of the patients and happens in the patients that I really care about when they're sick. I have to be on positive pressure breathing because I can't have ventricular interdependence. I have to keep the tidal volume constant. And if I have massive core pulmonality, then the right ventricle can have reverse interdependence, which is called the reverse Bernheim effect, and actually give a paradoxical pulse pressure variation. So with spontaneous breathing, the concept's very straightforward. As the right ventricle gets big, it squeezes and makes the left ventricle non-compliant. So this is a study which I published in 1985, which documented that. Here you can see spontaneous inspiration, pleural pressure falls in this animal model. This causes an immediate increase in right ventricular stroke volume, but note, left ventricular stroke volume at the exact same moment in time falls. That's ventricular interdependence. That's the decrease in stroke volume because the diastolic compliance of the left ventricle's changed. Wall stress hasn't changed. That's not Starling's mechanism. There's no change in wall stress. I've changed compliance. That's why I can't use pulse pressure and stroke volume variation during spontaneous breathing. But during positive pressure breathing, you see the airway pressure rises, causes pleural pressure to go up. Venous return falls, but left ventricular fall doesn't occur until later. That's no interdependence. Importantly, the greater the level of tidal volume, and here you can see a tidal volume of 5, 10, 15, and 25 mLs, the amount of blood that leaves the chest with the breath and coming back progressively gets larger the larger the tidal volume. So you have to keep the tidal volume constant. It's your forcing function. So if you have a tidal volume that's high then low, like in spontaneous breathing or pressure support, which the patient has significant variability, it doesn't work. So what should you use? Our esteemed chair here, in a study that he did with Jean-Louis Touboul, and they honored me with allowing me to be a co-author on this study, said, why don't we do what cardiologists have done for about 100 years, and that's a passive leg raise, which you don't raise the legs, you just rotate the bed. And what we did in this study is we measured the esophageal Doppler in a patient who was breathing spontaneously with atrial fibrillation. And as you can see, here's the passive leg raise, and this is the response to fluid loading. And in that study, Xavier showed that in fact, if you were a volume responder, you had an increase in cardiac output. And if you weren't a volume responder, you weren't. The advantage is that in spontaneous breathing patients, you can use passive leg raising. And this is why the surviving sepsis guidelines now recommend that you use this to assess volume responsiveness. Final point, is arterial tone normal? Well, baroreceptors maintain blood pressure as flow changes, so hypotension represents a failure of homeostasis. It's a medical emergency, but normal tension doesn't tell me a thing about the patient's vasomotor tone. So what I can look at is the relationship between mean arterial pressure and pulse pressure. If I increase my stroke volume, I don't double my mean arterial pressure. And if I have a drop beat, at the same point in time, my pressure doesn't fall to 0, it falls to some number, let's say 30. The slope of this line is called arterial elastance, and it's the beat-to-beat relationship between arterial tone and contractility. So, if I were to look at it from not mean arterial pressure, but pulse pressure, I can look at dynamic elastance. And let's assume that I have a given stroke volume and a given arterial pressure. And for the same stroke volume, my arterial pulse pressure is less. I must have a decrease in tone. And for the same stroke volume, my pulse pressure is higher. I must have increase in tone. And the advantage of this is that this isn't physiology, this is physics. This is how we define things. So I can use this dynamically at the bedside. This is an example from one of our patients who was bleeding, and we were giving fluid to her, had GI bleed. And this was the pulse pressure and stroke volume variation prior to fluid. She got some more fluid, the pulse pressure went up, the stroke volume went up, and then with more fluid it went up further. So you can actually see that the pulse pressure is getting bigger and bigger, the patient's getting healthier, the stroke volume is getting better, but the variations are going down. And this is, you'd expect, this is a pretty normal picture, right? This is nothing special. But if you were to look, the arterial elastance is progressively decreasing, and the variation is as well. This line is the elastance. As you can see, it's going down, and the pulse pressure variation. So you could have followed this dynamically. And in fact, Monge Garcia did exactly that, and what he showed was that if you had hypotensive septic shock patients, and all you asked was, I know they're volume responsive, I'm going to give them fluid, but will the blood pressure rise? He could not predict who would have an increase in the blood pressure, here called MAPR, based on systemic vascular resistance, the pulse pressure to stroke volume ratio, which is the shock index or mean arterial pressure, but dynamic elastance of greater than 0.9 predicted it. So we can say that if you have a high dynamic elastance and your volume responsive, even if you're hypotensive, just give them fluid, blood pressure will rise, otherwise not. The final thing is, though I'm talking about volume responsiveness, I also have a power threshold, which is the normal range of contractility. So to look at this with Joaquin Mas, we asked the question, if we gave norepinephrine to patients who had post-op hearts because the cardiac surgeon wanted us to increase mean arterial pressure by 20 millimeters of mercury, and wanted because he was worried about the left internal mammary artery perfusion. We saw that the mean systemic pressure, which you'll hear about in the next lecture, increased in all the patients. Right atrial pressure increased, and the arterial and venous resistance increased in patients. Congratulations, you gave norepinephrine. But the stroke volume variation fell, and in 10 of the patients, cardiac output went down, and in 6 of the patients, cardiac output went up. What we found is the patients who had a decrease in cardiac output started off with a stroke volume variation that was already less than 10, so they were below their cardiac functioning curve. And those who had an increase in cardiac output, it was all above 10. So you can use stroke volume variation as a measure of cardiovascular reserve and predict who will respond to norepinephrine with a fall or a rise in cardiac output. So I can use that I can use stroke volume variation as a measure of cardiac performance in my patients. And if I have decreased cardiac power and no stroke volume variation, the problem is the heart. And then I might want to do an echo or a PA catheter before giving them dobutamine. So the limits are, preload is not preload responsiveness. Number 2, I presume everyone in this room is volume responsive. I hope nobody in here is in shock. Just because you're volume responsive doesn't mean you need volume. But if you are in shock and you're volume responsive, give that person volume. The means of altering preload matters, tidal volume changes, passive leg raising, and the pulse pressure to stroke volume variation reflects changes in vasomotor tone. And the advantage is today, we're done.
Time is off, yes.
Yep. The advantage is these are all commercially available. You've got them right now in your unit. So the protocol is my patient stable, yes or no? If they are, have a nice day. If they're not, are they volume responsive? Pulse pressure, stroke volume, or passive leg raising, yes or no? The answer is yes. You don't stop there. You say, are they hypotensive with decreased vasomotor tone? Pulse pressure to stroke volume variation less than 0.9. If the answer is yes, they need not only volume but vasopressor. But if they have normal tone, all they need is volume, their blood pressure will rise. But if they're not volume responsive and they have decreased vasomotor tone, sort of like the septic shock patient you've given all the fluid to, they just need norepinephrine. But if they're sick, not volume responsive, and they have normal vasomotor tone, the problem is between my two hands. They need to start an inotrope while you're looking for the echo machine. Oops, and I can't make it any simpler than that. Thank you.